Livingston's Improvising Medicine. So we've been talking about the idea of biomedicine as human behavior, as something that anthropologists can study as a form of human behavior that is shared and learned among a particular group, particular population of people, and part of their way of life, the way that they are subsisting, the way that they are relating to others around them, the way they are thinking about the world. And so we have said generally that biomedicine is capitalist in the sense that it is something industrially produced, market distributed, individually consumed for profit, right? This is some of the characteristics of the kind of economic component of culture that produces biomedicine. It is part of a market competition, right, between different actors that are producing medical sorts of goods and services for profit and financial gain. This is a cultural perspective, right, on biomedicine. And so final component is the idea of the ethics of this. We've talked about how in anthropology, when we're thinking about cultural issues and we're thinking about cultural criticism, we raise questions about the ethics, right? Is this form of culture good or bad? Is it morally right or wrong from a particular perspective? And so it raises this question around the ethics, right, of how medicine is distributed and accessed by people, particularly marginalized and disempowered people in the world today. On this topic, then, we are reading the work of Julie Livingston. So Julie Livingston teaches at NYU. She has an interesting intellectual pedigree. Her PhD is not in anthropology, but it is in history, although her history is very informed by anthropological methods and theory. Kind of contempt history would be the parallel with anthropology today. But she also brings her own biomedical credentials to the study. So she has a master's of public health and health services from Boston University, and she has a certificate of public health in developing countries as well from Boston University. And it's with this background that she conducts research, one could say cultural criticism, on biomedicine in Botswana. The ethnography is about a small cancer ward at Princess Marina Hospital in Botswana during an emerging cancer epidemic. Now, interestingly, while Botswanans generally have a lower probability of developing cancer there than, let's say, if you were to compare with European or North American populations, they actually have a higher probability of dying. So when we think about the issue of disparity here mortality, cancer mortality is distributed unequally, right, across, one could say, geographical regions, nation states, and so on. So for the ethnography, it's this issue of this epidemic where you have high rates of mortality for cancer. And so what her text does, what her research does, is highlight how Botswanan biomedical practitioners sort of improvise within the context of having scarce resources. In a sense, the text explores what might be called the theory-practice conundrum, the theory and practice conundrum. So from one perspective on biomedicine, one could call it the theoretical perspective of biomedicine, you would have early testing for cancer, you'd have the latest technology, you'd have highly skilled surgeons and other specialized medical personnel, right? We would have a representative from a medical technology company, potentially representatives from the pharmaceutical industry. You would have a range of universities and other research organizations actively cooperating and participating. But as we understand, that's done for profit. And relative to North America and other developed countries, incomes in Botswana are far lower. Now, some of the statistics don't show that because, in fact, there are diamond resources in Botswana. And so if you look at the GDP, let's say, or average incomes. Botswanans have a relatively high income. It's very important to think about how that really is, that income and those resources are focused in about 10% of the population, and 90% of the population has very, very low or no income at all. And so the private market for medical services doesn't exist. It's very small. And so the government does invest through things like tax into public health care, but that public health care exists within the context of scarcity. So if you think about the diamond industry, most of the resources that get produced through that, which is capitalistic, also is transformed into profit and goes to private individuals, where the tax base is only a small percentage of that. Something to keep in mind for why Botswanans are struggling, right, to meet biomedical theory in terms of what care should be and the reality on the ground, which is minimal testing, minimal radiology equipment for treatment, and a real emphasis on late stage treatment, things like amputation, end of life palliative care. The reality of what can be done with the resources really are quite different than if we only thought of biomedicine, right, in theoretical terms, or only if we looked at biomedicine from the perspective of North Americans. One of the other ways that you can see this is the issue of pain. So where Botswanan biomedicine is focused on late stage treatment and focused on end of life care, as these advanced cancers develop, they can be quite painful for a patient. And like other forms of scarcity, they have an absence of pain relief for cancer patients. And the text explores how morphine as a commodity, the majority of it is consumed by the richest countries who can afford it. And so because of economic differences of a place like Botswana, they have less access to things like morphine, less access, right, to be able to manage the pain of patients. And so we've been looking at biomedicine and cultural criticism, and that's been the focus. Although the text also gets into culturally specific, Botswana-specific forms of end-of-life care that develop, right, in this context of scarcity. So an alternative kind of system starts to fill in there that doesn't fit a kind of biomedicine described in broad terms, something that overlaps, let's say, North America and Botswana. There, something within that unique context develops in terms of palliative care, the forms of social connection and social relatedness that step in and fill in, right, in the context of scarcity. So to conclude, we're exploring through one example what we were calling a cultural view on biomedicine, looking at it as capitalist economics, as this competitive way of producing goods and services, as a commodity, right, on a market, on a global market. And so the case that we're looking at looks at one area of biomedicine specifically, that is oncology, within the context of sub-Saharan Africa, South Africa, and Botswana, a poorer country in the world relative to other, large countries like the United States. The ethnography focuses on kind of the disparities and the differences, the tensions, the conflicts between, on the one hand, how we think of as best treatment, best practice in biomedicine, and then sort of in that context, how actual practitioners have to improvise. They have to adapt to a local context. One type of economy where people may be more poor, right, and resources, financial resources are less plentiful, and thus the ideals of what kinds of technologies and equipment are purchased and utilized what kinds of drug treatments and so on are purchased and utilized are quite a bit different. In this improvisation, right, we see the conundrum of providing care. The ethical issues and questions that we've looked at are there, as well as some of the culturally specific ways that Botswanans, right, have been struggling, right, with those problems and trying to fill the needs of scarcity.